Hi, everyone. Welcome back to our CT and MRI lecture series. It's a great pleasure today to have Dr. Rohan Khera that is going to be joining us from Yale, and he will be talking about personalizing chest pain evaluation with machine learning. He will be focusing on a recent publication in the European Journal of Cardiology that I thought it was amazing. And briefly, he's an assistant professor at Yale, and he has won many awards for his short career. Still, Young Investigator Award at the American College of Cardiology 2019, Young Investigator Award, American Heart Association 2018, and multiple other ones like the Outstanding Junior Resident Internal Medicine, University of Iowa, and Quality of Care Outcomes Research from the American Heart Association in 2015. So it's a great honor to have you here, Rohan, and thank you for joining us.
Oh, thanks, Leandro, for inviting me. I appreciate the opportunity to speak to the group. I am an assistant professor of cardiology at the Yale School of Medicine. I'm an investigator at the Center for Outcomes Research and Evaluation, and I lead a group that is focused on the intersection of data science, healthcare quality, and personalized care. For this talk, I have these disclosures. I don't have any financial conflicts of interest. However, I'm reporting funding from the NIH, and the tools discussed in this study, I have to specifically point out, are research tools and have not been approved for clinical use. So first off, because we're talking about the study, I am going to focus this discussion entirely around a recent publication in the European Heart Journal. And for folks following along on the side, if you don't have access to the publication, if you point your screen or your camera to that QR code, you should be able to download a copy of the paper. It is available open access. I'm going to pause for a second to allow folks to do that. Perfect. I hope each of you has a copy of the study and can follow along. It'll help the discussion as we would have time for Q&A at the end. So first off, why go after a question of this nature? If you look at the most recent guidelines that around recommended testing for stable coronary artery disease, what you find is the European Society of Cardiology guidelines from 2019, since the AHA-ACC guidelines have not been updated in a while. There is a class 1 level of evidence B guideline recommendation for non-invasive functional imaging or myocardial ischemia or coronary CTA without any distinguishing characteristics reported in the guidelines regarding how to choose one test over the other. So there's truly an equipoise in the guidelines about choosing the test of choice. However, they do say that the choice of test can be based on individual patient characteristics. And the things that they focus explicitly on are test performance and whether there is local expertise and availability of these tools. And this is sort of reflected in a graph that is also presented in the same guidelines, where it suggests that given the high negative predictive value of CTA and the risk of false positives with higher coronary calcium burden, that coronary CTA is more useful for individuals at the lower end of the risk spectrum. And conversely, individuals who have maybe a higher likelihood of obstructive CAD, but not, very high probability, a more functional assessment may be appropriate. However, this is not based on any specific outcome-based study, but just test characteristics of these two studies. However, there have been large randomized clinical trials that have compared these testing strategies head-to-head. Specifically, the largest trial to date is the NIH-funded PROMISE trial, where anatomical and functional testing was evaluated among patients presenting with suspected stable coronary disease. Over 10,000 individuals were randomized to either receiving a CTA or coronary CTA, or functional evaluation with either a nuclear stress test or ECG or stress echo. For 10,000 individuals, 5,000 in each arm were followed over a 2-year period and outcomes evaluated were all-cause mortality, MI, unstable angina, hospitalizations, and procedural complications, specifically in this study, included stroke, bleeding, renal failure, and anaphylaxis. And what is really keen to know that even after 2 years of follow-up, this large population of patients, there was no significant difference between anatomical or functional testing in terms of clinical outcomes at 2 years of follow-up. People have evaluated subgroups where they have seen whether coronary CTA or stress test was better suited in terms of outcomes. A specific subgroup that has been mentioned in multiple prior assessments is gender. Is there a gender difference or different by sex among response to finding groups that benefit from CT or stress test? So this study published in JACC from Promise focused on a specific evaluation. So this is a complicated graph, so I'm going to quickly walk through a few aspects of this. That among women and in men, overall promised results held up, that there was no difference in clinical events based on either the yellow bar, CTA, or the red bar, the stress test. However, there was a difference in the proportion of patients who had a positive stress test, that women were more likely to have a positive stress test and men were more likely to have a positive CTA, suggesting the potential for coronary artery disease. However, what they found in the study is that among women who had a positive CTA, this yellow bar here, they were more likely to have five-fold higher rates of events in those who had positive tests versus those who did not have a positive CTA. There was a lesser gradient or lesser discrimination of risk by stress test among women. This was actually reversed among men who were more likely to have stress test being the test that had a higher discrimination of events versus a CTA. And as you can imagine, these are broad subgroups and can ignore phenotypic diversity among men and women. There was also a similar evaluation among patients with diabetes. And just to summarize, the red bar being computed CTA, coronary CTA, and blue bar line being the stress test. And among individuals with diabetes, CTA was associated with a lower risk of primary composite endpoint of MACE at as far as 3 to 4 years of follow-up. But they do not find this affecting patients without diabetes. However, as I mentioned before in the gender example, these examples and studies, these post hoc assessments on single groups miss the great phenotypic diversity within patients with diabetes, within men and women and so forth. So, and I would also be remiss to not mention the Scott Hart study. So one of the things that I explicitly want to mention that Scott Hart did not test coronary CTA versus stress test in their study. It focused on the addition of coronary CTA to standard evaluation, which could vary from anywhere from not doing any other non-invasive testing to actually pursuing stress tests. And in this particular study, around 4,000 individuals were randomized to either CT or standard care. And the composite endpoint was different, was CHD death or MI. And at this around 4 years of follow-up, actually the 5-year follow-up mark, there was a nearly 40% lower risk of this primary composite endpoint among individuals who had a CTA. The objectives of this current study were to, one, evaluate the heterogeneity in outcomes across the phenotypic spectrum. So not restricting to specific groups, but across the diversity of the phenotypic spectrum. And two, personalize the selection of the optimal diagnostic test, not based on test characteristics alone or patient habitus, body habitus, and features like that, but rather features that are most likely to achieve the best outcomes for individuals. For this, we use the study population of the PROMISE trial that we obtained through the BioLink as sponsored by the NIH. I will start on the right. This is a complicated plot. I'll start on the right. It just defines the distribution of individuals within the trial. The study arms, as I mentioned, were functional and anatomic testing. Anatomic testing included individuals who had a CTA, and functional testing was split mostly around nuclear stress testing, where nearly 70% of the people had a nuclear test, while the others had echo and stress ECG. Please note that these individuals predominantly followed the randomized pattern. This was the randomized test that they were supposed to undergo, and this was fairly consistent that they actually underwent the test that they were randomized to. And the study does report what test did they intend to perform if CTA was not available. And a large proportion of the individuals had stress nuclear as a test of choice, even among patients who eventually underwent CTA. This was just a subjective question asked of the individuals. And one of the interesting aspects of the study in PROMISE is that they did enroll enough men and women, and they had nearly half of these in the population. And our goal was to characterize the heterogeneous treatment effects within this null PROMISE study, but only using pre-randomization characteristics, because we did not want to bias the treatment selection cascade and that being the basis for determining future test strategies. So among patients, PROMISE trial participants were defined by patients who had chest pain suspicious for CAD. We extracted baseline clinical phenotypic variables, including demographics, risk factors, their presenting symptoms classified as Diamond Forrester scores, ECG characteristics if they had underlying baseline abnormalities, the medications they were taking, especially the key cardiovascular medications, and there other clinical assessments that was performed initially. And all these features were extracted, and we were agnostic about the features used as long as they were consistently reported across the trial. In the end, we ended up including 56 unique features for each individual included in the trial for our analysis. These were transitioned to, so while in each individual in the trial would be represented by 56 covariates, that would mean that these individuals have 56 dimensional space, and each person has is a dot in this 56 dimensional space. However, you cannot visualize how a person can be represented in 56 characteristics. And therefore, we included an additional aspect in our study of visualizing this 56 dimensional space in two dimensions in this 2D view. And when you look on the smattering on the right, each dot in this map represents a person that is represented in that multidimensional space. As you note, that all these factors were pre-randomization. So we did not focus on finding randomization or the test they underwent in creating this phenomap. So randomization was distal to the initial one. And individuals, as mentioned before, either underwent anatomical or functional testing. And then among this group of individuals, we performed something called a neighborhood analysis or topological analysis, where 5% of the trial around each person was assessed as a local experiment in this diverse space. So by the virtue of the fact that we used 56 features to define each individual, and individuals were present in this multidimensional space, each person is the center of their own cluster represented by the rest of the trial population. We chose 5% of this population to define the individuals who closely resembled the individuals. And we did pursue additional analysis regarding the choice of this distance. And from this 5% cohort, this sub-selected population that resembles each individual, we found a neighborhood-specific hazard ratio. So for each person among these 10,000 individuals, you had a unique hazard ratio for adverse outcomes if they underwent anatomical or functional testing based on the people that resemble that individual. And I think I'll quickly go to the visualizations themselves, because I think they provide a lot of information regarding the testing. So one of the testing strategies on the left here, you have treatment allocation. And if you focus on the treatment allocation, this is, again, each dot represents an individual in a multidimensional space. But what you can see cleanly is that functional and anatomical testing, the two study arms, are uniformly distributed across the UMAP. What it really means is that randomization was maintained not only in a specific neighborhood, but all neighborhoods maintained randomization. We also plotted the baseline ASCVD risk score, or the pool cohort equation risk score, just to evaluate for two major things. One, is the UMAP capturing differences in baseline risk? And as you can see, there is co-localization of a higher risk score versus a lower risk score spectrum. And these have all been normalized to Z-scores to ensure that they are consistently represented. And then, but you also see that, there are higher risk individuals who are represented on the other lower risk spectrum of the map, highlighting that even among high risk individuals, based on like simple tools like the pooled cohort equations, there are additional features that may not be captured, but may make them more similar to other people. And that is where the power of including multiple pre-randomization features comes in. And these are the results of the phenomap directly. So if you, instead of plotting the risk factors, now if you plot the results of the outcome, the hazard ratio of neighborhood specific effects, the red end of the spectrum represents favoring anatomical testing. So groups presented in each individual here would have much better outcomes with anatomical testing versus those in the dark blue here, where functional testing would be more favorable in terms of outcomes. And what does this mean in terms of the distribution? As I said, the major adverse cardiovascular events, the previous phenomap, for if the entire hazard across the 10,000 people were presented as a distribution, you would find that since this was a null study, the log hazard ratio is close to zero, and all other individuals are distributed around this central hazard. However, the hazard ratios vary substantially across the trial. And the distribution of the plot varies by the outcome chosen, but all-cause death in MI, a common outcome used in other trials, similarly had a vast distribution along with functional anatomical testing was favorable. And as I mentioned before, we did focus on understanding if our neighborhood size effects would change or influence how we study the effect of the intervention. So we went and evaluated from a neighborhood size of 2.5%, which means that each individual is only compared to 2.5% of the trial population. In a 10,000 person trial, that would be 250 individuals. So each person was compared with 250 people surrounding it, with 500 people surrounding it, 750, 1,000, or 1,500 individuals. And although these are smaller plots and harder to visualize, but if you can just notice that the red and blue separation is much higher in smaller neighborhood sizes versus a larger neighborhood size, suggesting that the risk dispersion is high in smaller neighborhoods. But then the other challenge, though, is that neighborhood affinity or a measure of neighborhood distance, how dissimilar individuals are in a neighborhood, which has implications for the local nature of the experiment, is that you have more homogeneous neighborhoods, that blues and reds are separated if you have smaller neighborhood size. And if you have a larger neighborhood size, the blues and reds tend to mingle with each other, meaning that each neighborhood is being compared to a lot of dissimilar individuals. So large neighborhood size have negative effects there. So instead of deciding different factors, we stuck with the 5%, which we felt was an optimal distance, had a large enough number of events, but still homogeneous enough population that you could compare differences. However, we did iterate using these multi-state models, this Monte Carlo simulation, and found that the log hazard for a 5% neighborhood compared with one drawn from a 2.5 to 10% distribution was very consistent, was fairly consistent. You had a fairly linear relationship between a choice of 5% neighborhood or another neighborhood. And how do you best conceptualize the phenomap, say, for a given patient? So you could take an example like this, a 59-year-old woman with diabetes. And this would, kind of go with the examples that have been tested thus far. But we mentioned that, hey, why don't we add another features with that woman also has hypertension, has never smoked before, has no dyslipidemia, and is presenting with atypical chest pain. And if you were presented this case scenario, you would go after and say, I would pursue one test or the other. But what is challenging in this particular situation is that if we use our phenomap to study the same individual based on these 5 features, we found a total of 3 people that resemble this exact description. The first person, which is the I marked on the phenomap crudely here as 1, you have and the plot here, which will be consistently represented throughout, is that the red bar is event-free survival with functional testing, and anatomical testing is lower. Here, anatomical testing was associated with worse outcomes, with 4-fold higher risk of adverse events with anatomical testing in individual 1. A second individual in the phenomap, same characteristics, actually had no significant difference between the 2 study arms. And it was completely flipped in the third example, where anatomical testing was 4-fold likely to be superior to functional testing. And why does this matter? This matters because in addition to the features that were already captured, there were differences in race, blood pressure, medications used by the patient, their BMI, their cholesterol values, that all had implications in classifying them into these 3 different buckets, saying that you could go by a big question stem, but still not be able to infer what would be the best outcome for a given individual. So, but another aspect to this is, as I mentioned, there were 56 pre-randomization features we used. But how do we translate such a phenomap to a clinical trial practice? That is where I believe the value of ASSIST comes in, which is a tool that, as you can spell it out, anatomical versus stress testing decision support tool, which employed extreme gradient boosting tree-derived decision support algorithm, which is a machine learning tool that parses multiple features and their interactions to come up with the features most consistently associated with having a beneficial effect from anatomical or functional testing. The other aspect that is important, why this may be important, is that there is likely to be a lot of random variation that some neighborhoods, by chance alone, may have favorable effects from anatomic testing or functional testing. But all across the trial, you would be able to identify features that were more consistently associated with it. And we found that using a metric called SHAP or Shapley values, hypertension, diabetes, and female sex and so forth had descending order of importance in being classified for favorable effects with either anatomical or functional testing. What it means is if in the presence of hypertension or the absence of hypertension had a significant effect on whether a patient would have a favorable outcome with anatomic testing or functional testing. And we also were able to figure out what the low and high values would indicate that a low value or the absence of hypertension in this particular example would favor functional imaging. And we were able to similarly find that a yes or a high value of diabetes or presence of diabetes would favor anatomical imaging, which is consistent with the prior study as shown before. So there are these multiple features that had consistently better association with either anatomic or functional testing. And we fit a second order XGBoost model to build a score and calculate an individual person's hazard ratio from the actual distribution of just these 12 key features. And if based on our predicted in the training sample itself, so the PROMISE trial was split up into 80 and 20, 80% being the sample that was used to train the XGBoost model. And there was a testing sample, which is the 20% that was not used to train the XGBoost model. And we found that the distribution of hazards was consistently throughout, and the assist predicted hazard ratio was distributed across the spectrum. And similarly, the distribution was consistent, like the plots before, across functional anatomical testing based on the assist-based hazard ratios. So assist did not find hazard ratio distributions that were discordant from the predominant trial in either training or testing populations. However, there was a consistent association with outcomes. And because these are dense plots, I would take a second to explain what they mean. So if the assist recommended test is anatomical or functional, it was compared against the test actually performed, anatomical or functional. And if they were consistent on both the anatomical arm, that anatomical was recommended and was pursued, then it was given a purple bar or purple color here. If, however, the functional test was recommended and the functional test was performed, that was a red bar. However, if there were discordance in the test recommended by assist and the one actually performed in the trial population, they were labeled with this green and teal color respectively. So in the 80% PROMISE trial, using the assist tool, we found that a concordance of the assist recommended test and the test actually performed, which are these purple and red bars, you were more likely to have freedom from primary PROMISE endpoint. However, individuals who had a discordant test were much more likely to have a major adverse cardiovascular event. Although the PROMISE training trial, this was based on cross-validation within which the tool was actually developed. So there is a likelihood that the model just learned some features that were not really true representations of the people, but what we call as overfitting in the model. And but we found a similar signal in the 20% testing population of PROMISE trial, which is 1/5 of the PROMISE trial that had not been involved in model development. And we found that the red and the challenge here is that the purple and red overlap so cleanly that you're unable to visualize, but they are overlapped. That if you had the test recommended by assist, you were much less likely to have a major adverse cardiovascular event, even in an independent trial population. And we did present this as a statistical interaction. There was significant interaction by the recommended, if you had a test that was recommended by assist versus if you did not. But how does assist generalize outside the PROMISE trial? We did not want to create a tool that worked in PROMISE trial, but did not have any meaning outside the trial. For this purpose, we focused on the Scott-Hart study. I mentioned before that the trial did not test CTA versus functional testing. However, based on the fact that individuals in the Scott-Hart trial did undergo only anatomical testing or only functional testing in a subset of the population, we chose that subset for external validation, which includes 301 individuals who had anatomical testing alone as the first test, which is they underwent a CTA, compared to 1,800 individuals who actually underwent a stress test or a functional test as their first test, with a median follow-up around 4.8 years, and just using the primary endpoint of Scott Hart itself to validate assist. So even this graph follows the same schemata as the previous one, and you found that among people who were recommended anatomical testing by assist or recommended functional testing by assist, and they underwent that test too, they were much less likely to have a major adverse cardiovascular event defined as the study primary endpoint of CHD or coronary heart disease death or MI, compared with individuals who had a discordant test. The recommended test was not the one that was actually pursued. There were worse outcomes. That is as I mentioned before, we were comparing 301 individuals to around 1,800 individuals who had stress tests. So we created a propensity matched subset of this population and still found a similar separation across the two groups. And there was a significant interaction by the test recommended by assist and patient outcomes if the test was actually pursued. And we also repeated this analysis for a harmonized endpoint. We did not want to just compare primary endpoints, but where was the same endpoint consistently tested and would reveal the same results. And we similarly found that if a functional test was recommended or an anatomical test was recommended by assist, pursuing an assist recommended test was associated with better outcomes compared with not pursuing a test like that. And it was the outcomes being all-cause mortality and non-fatal MI that were both captured in PROMISE as well as in Scott Hart. So how do we apply assist in a clinical setting? So we have converted this into a web-based tool. And I'm going to pause again for a second. This QR code should be able to take you to the web-based tool that has this tool that you can actually enter any of these 12 features. And you have continuous range. The blurb above tells you the performance ranges. So since the PROMISE trial included people from 45 to 90, that's the range of age groups that we would recommend here, and so forth for each characteristic. If you click submit, assist would give you which test was recommended. It will give you the relative hazard based on the tools that I just showed you. But it will also give you how far the hazard was in terms of the original distribution in the PROMISE trial, such that we were identifying extreme differences in anatomical or functional testing in terms of the hazard, or which test would consistently or more strongly, or how confident we are in the estimate that the test recommended by assist was consistently better or worse. So in summary, there's a large heterogeneity in outcomes with testing strategy in the PROMISE trial. A series of local experiments in a high-dimensional phenotypic representation of a trial participant can uncover this heterogeneity. And machine learning based assist is a practical tool that individualizes the choice of anatomical or functional testing by giving you a personalized risk estimate of adverse outcomes with pursuing an anatomical or functional testing. There are some limitations. We have limited mechanistic explanations based on why a person would benefit from anatomical or functional testing. That's a challenge with the field in general, where multiple studies sometimes show differences similar to Scott Hart, but there are no clear explanations, and it may represent a combination of further downstream testing, revascularization, use of guideline-directed therapy, including aspirin, statins, and the choice of other drugs, and care and follow-up that may vary among individuals based on the test they undergo. I also want to point out this is a post-hoc descriptive analysis. This is not prescriptive, has not been prospectively validated. And the validation data from Scott Hart was a selected subset due to different trial design. So that validation is not in a true trial sense, but it still represents a validation of the population. So we, based on the limitations I just discussed, we are pursuing validation in the Yale New Haven Health System. We're pursuing initially a retrospective validation among individuals who have already undergone either of the two testing strategies. And prospectively, we're embedding an EHR-based randomized trial that pursues the assessment of assist in a prospective manner. And we are also assessing non-cardiovascular outcomes and therapeutic as well as financial implications of choosing one testing strategy over the other based on assist. And then our final point I would make is that, as you may pick away, that this tool and this approach is not restricted to stress testing or what we do in among patients with suspected coronary artery disease, but it has a wider application to other clinical scenarios. I would specifically want to acknowledge our first author of the study, Evangelos Economou, who is a resident physician at the Yale School of Medicine, including other collaborators from Yale, from UT Southwestern, UCLA, from Oxford. And for data access, BioLink and NHLBI funded the trial, PROMISE trial, and we received access to the Scott Hart study from David Newby at University of Edinburgh. Thank you, and with that, I can take any questions.
Thank you very much. That was amazing. I think it's not only is exciting what you're presenting. I think it's such a promising technology that I think probably all of us are very excited about it. So please put your questions in the Q&A. I guess I'll start with a question or two questions. I think first one would be, are you planning to use this in more of a real world too? Does it have any value of doing it in patients outside the randomized trials? And the second one is probably a lot of these effects are related to what you do after the test, right? Have you thought about doing it in like an ischemia trial, for example, population or something like that?
These are excellent questions. I mean, I kind of break them apart into two. Is validation in a real world population? I think as I mentioned, we are trying to do a local validation. We have the largest chest pain center in our region, which has around 10,000 tests performed over the last couple of years alone, and we have the ability to track them over from their outcomes. The major challenges, I would say, where clinical validation is concerning, is that you do not have as consistent follow-up or as you see in clinical trials. However, we are trying to build an EHR-based cohort among individuals who have consistent follow-up to see if we can evaluate these effects. So yes, the answer is we are initially pursuing a retrospective validation, but then eventually, if the retrospective evaluation does not yield any safety signals, we would want to pursue prospective validation. There are some aspects that I think merit some consideration, that the unbiased treatment allocation in randomized trials is an advantage. So if the validation does not hold up or is weaker than the one seen in trial, is that representative of the failure of the protocol or the algorithm, or is it just a representation of how clinical world varies, or there is already some bias in how we decide these tests in the real world population? And these are considerations that we plan to encounter in the future. And then your second question around what is the mechanism behind seeing the effects that we observe? And that's an excellent question too. And I would say all these in ischemic heart disease, because of the complexity of the care we provide and whether one person has a beneficial effect from, say, aspirin, statin, determination of if they have left main disease, revascularization for that kind of disease, all these are reliant on the fact that you were able to diagnose these effectively upfront. So our strategy, especially in the population, in the PROMISE trial itself, is to tease apart if there were specific subsets in terms of therapeutic management in the follow-up of these trials that give a sense of the mechanism behind this outcome. But that's definitely a work in progress for us.
Great. So we had also Piotr Slomka from Cedars-Sinai. I don't know if you know each other. Hi, Piotr.
Hey. I think you're muted.
I can hear you.
Yeah, sorry, I'm muted. Yeah, very interesting lecture. You're really on the, trailblazing. This area is very, very important area.
Thank you. I appreciate it.
If I had one question or comment is this calculator, like a web-based calculator you present, is very interesting. I think that's the kind of way to go. Is that something, how do you see people use it? Does that need to be regulated in some way? Like, or is it just like a research tool? Or if we actually put it in a clinical care, will it be something, doctor will rely on and put in the report, they use this calculator, and like, what do you need to get there?
That's a great point. So I think there are two aspects to that question. First, what is the regulatory aspect of this calculator? We would say that the pool cohort equation that we use to make clinical decisions on a daily basis were developed in observational data sets. We still make decisions based on that. But the reason we are able to rely on that, in choosing patients who get blood pressure therapy or diabetes treatment or statins is because they were validated in multiple different studies. So one of the ways that we can improve the confidence is this prospective validation in multiple different settings. And so that's something we are pursuing at a local hospital and are looking at partners nationally who would, would be sites to develop this. Second is these are not just regression-based tools where you can say, hey, presence of feature X gives you a multiplier Y, results in the change in risk between anatomical function testing, but there are multiple interactions built in. So the presence of hypertension, absence of diabetes, a given cholesterol value would give you a different result than even if one of them was different. So they're not additive based on the fact that we're using XGBoost to construct this. We have an API, a web, API that can embed this into a EHR, and that is actually part of the prospective validation within that I discussed, that it can be turned into a clinical decision support tool. For now, I think it will be something that will be just reflected in the chart as any other decision support tool currently is, that based on the assist tool, the anatomical testing is favorable, but this is not to make clinical decisions, but just to provide you a personalized interpretation of the PROMISE trial.
And that's great, so exciting. And we have a few questions from the audience. From Dr. Menegos, one of our interventional attendings, director of the cath lab, says, understanding the limitations of how this was derived, do you think there is a fair amount of post-test bias in the management of the cases? In example, low-risk tests do not go on for a further study.
Oh, I think that's the key point, and I think that's where some of these mechanistic explanations would be important. Is that you choose a low risk test, and you have a low risk stress test, for example, and it was done in an individual who had balanced ischemia, and but was missed because of the given individual stress characteristics. You're unlikely to send them out for either both therapeutic cascades for medical management and procedural management. And those are the aspects that I think are the reason there is a separation that we see. That if you, I'll give you an example of the diabetes study that came out in JACC a couple of years ago. The benefit of CTA in diabetes probably doesn't come from the direct revas or just choice of statin therapy, because probably most of the individuals are receiving statin therapy. The benefit probably emerges from the identification of surgical disease early on, with the known association of surgical management of complex coronary artery disease and reduced risk of adverse outcomes. So, the appropriate classification of tests. So what PROMISE allowed us to do is that because the test was used in an unbiased manner and the treatment cascades followed, whatever followed from the treatment cascades just happened to kind of take place, we didn't at least bias the test by a preconceived notion of hey, this person's going to go to CTA or this person's going to go to stress test. But we did find that if a test was unlikely to be, or was likely to be a false positive or a false negative, those things would be picked up and reflected in the downstream outcome effects. So, I think what I'm trying to kind of summarize a little bit is that if you have a population that benefits from a test and is the right population for the test, doing that test in that particular population likely has outcome implications from the downstream effects. And what we can capture as an outcomes investigator is that I cannot capture the mechanisms behind those decisions, but I can study the number of individuals who are harmed or benefited from the therapies.
Great. We have one from Dr. Damini Day, also a world expert in machine learning and artificial intelligence. Excellent presentation. Can you comment on the ROC area under the curve for events in PROMISE and Scott Hart?
So because I would like to point out that this is not a binary representation of risk. So we did not have, hey, this person gets risk A or benefit, or, you don't get an effect estimate 1 or 0. We present risk, the benefit from the therapy on a risk continuum. So a person has a hazard ratio X, and that hazard is just a representation of that person's benefit from getting anatomical or functional testing. It does not, say that, hey, this test is better or the worse. That's why I think I would not put too much credibility into the recommendation of the test from the tool, recommends anatomical functional testing, but actually the degree of the hazard of separation from, the magnitude of the hazard ratio. So I think I do not comment on the ROC because we didn't build this as a predictive algorithm for, hey, go get test X and Y, but like how likely were you to have an adverse event or a major adverse cardiovascular event if you got anatomic or function testing?
Interesting. And from Ethan Goldberg, we have another question, and I'll put one from here. Are there any ethnic or racial differences in performance, and how much a calcium score could, if we incorporated that into the predictor model, how could that affect it?
That's a great point. I mean, I think algorithmic bias is a major challenge that we recognize. The hope was that because Promise was a randomized clinical trial enrolled in North America, both US and Canada, that we would not have these biases towards testing that are seen in real world setting actually creep up into the model. We did not have the ability per se to choose specific population, or I should put it better, we chose to not be biased in our design of the tool or like selective in the choice of either predictors or outcomes. But what I can mention is that in the features that were selected by the model, race was not a feature that predicted either benefit from anatomical or functional testing. So the 12 features that finally represented in ASSIST do not include race, suggesting that race, as far as a randomized trial goes, was not a predictor, and other clinical features probably were.
I think it's a lot more interesting also if we could use this versus now we get all these notifications on is this test appropriate use criteria that many times doesn't fit the patient. So hopefully this will replace those criteria. Another question for both Piotr and yourself, do you think this could be used for also the quality of the test that we'll acquire? Is it the best quality, for this patient, we're going to get a good quality test or a poor quality, for example, obese patients or?
That's a great question. I mean, I can start off with a general assessment. My sense is that quality of test, based on the fact that we see outcome implications, it is conceivable that the outcome, that the quality of the test and therefore the quality of the test result are improved by choosing a test that is more aligned with the person's specific characteristics. But that was not something we explicitly tested, was mostly because it's challenging in a post hoc analysis to see whether the test quality was better. But I think that's definitely a player because we see BMI being a predictor, we see age being a predictor, gender. So those features suggest strongly that there must be a quality aspect to this.
So I think it's a great point. I don't know if you actually use specifically quality of the test as one of the variables in your training, but if you had it like either for training or even like as an outcome, you could develop this kind of model where you would predict this is not going to be a very good test because of the quality. I don't know if you had that kind of variable there.
We did not. I mean, honestly, This is a great discussion point for us because it just gives us new leads of investigation, but definitely makes sense to, especially because we would not want to do it pre-randomization. But as an outcome, I definitely agree. Study quality is a major factor, but we did not look at it thus far.
So one of the things when we do this, we do it in a very different domain, but we work with the same tools, like with the XGBoost and Shape and all the. So this explanation opens up a lot of the interesting like thinking into this. And in your calculator now, do you have this SHAP implemented so you can see for if you type in the patient special, the recommendation comes, does it tell you why? Does it show you this SHAP features?
Not in the score per se, but yeah, on the back end, definitely.
Back end, right.
Yeah, back end, definitely. That's because I think that was used to define the features that will go in the model. SHAP was. So we have the ability to visualize a SHAP for a person. So this is not interpretable. This is truly an interpretable test. But for the purpose of being front facing for individuals using the test, we don't deflect those values. But yeah, easily, we could say presence of X and absence of Y was the reason that the test suggests one test or the other.
Yeah, and it could be like what Leonardo said, like, for example, if quality was included, it could be that, that test could result in a bad quality. That's why, they don't want to do it. Yeah. So those kind of things would come up with this individualized explanations, which is
I think that's where I think from a technical perspective, Shapley values are advanced because they offer interpretability outside of the model specifics use. You could use any tool. If it's not XGBoost, sometimes it's another model, still can use a similar framework. So, I think we're pretty excited about the possibility of extending this and making it as interpretable as possible so clinicians trust it and, can kind of use in clinical practice.
Yeah, it sounds very, very promising. So great job and congratulations on your work.
Appreciate it. No, thanks for having me. And I appreciate the opportunity to discuss as a team.
I think there's one more question from Damini. It says, are previous CAD or revascularization included in the calculation? I would assume not, right? But do you?
Yeah. So, and not in the tool itself. Again, I would kind of still specifically highlight the fact that we did have those features included as study covariates if somebody had existing thing, but PROMIS didn't. So risk was, CAD wasn't, because this is truly a diagnosis of CAD study. So PROMIS included people with suspected CAD, not with existing CAD. But it did include people across the risk spectrum with a high risk and across low risk.
There is one more question I see here on the question and answer, which is from Ethan Goldberg. How might a prior CAC score affect the decision model?
Well, that's a great point. I think that was not something that was captured. So unfortunately, that was not featured. But we are in the process of, because that information is captured in clinical cohorts as well as in our real world setting, like in our clinical populations, we would be able to incorporate that information. So again, all these were like not pre-randomization features that were available back in 2015 when the PROMIS trial was published. The primacy of CAC scores probably emerged more so in the last 5 years than before.
Thank you very much. Very exciting, and we'll be waiting for your next paper and your next publication.
Well, appreciate it. Thank you so much.